Short. Good evening. I'm Namrata. I'm a postgraduate registrar from Department of General Medicine. I'll be presenting a short case. This is Mrs. Chitra, a 51-year-old homemaker from Unjaripet, Vellore, who presented with palpitations, breathlessness, and lightheadedness for 30 years. On examination, she is alert, oriented, and comfortable and cooperative with examination. Pulse rate was 72 per minute, palpated at the right radial artery. It was regular with high volume and a collapsing pulse was present. There was all peripheral pulses were present and there was no radiofemoral delay. Blood pressures. When the pulse is palpated at the radial and when the arm is raised, it can be, there's a
abrupt upstroke leaves the stain please, and a sudden downstroke, and the reservoir seems to collapse near palpitating. What are the causes of the collapsing pulse?
Aortic regurgitation, hyperdynamic circulatory states.
You say it in terms of what's the most common thing. What disease is for the collapse?
Aortic regurgitation. I don't know any of that.
What about PDA?
When you have patient collapse, mentally you anticipate that they are going to ask you and have a area.
Blood pressures in the right upper limb was 126 by 42 millimeter mercury. In the left upper limb, 130 by 44 millimeter mercury. Systolic blood pressure in the right lower limb was 180 millimeter mercury and the left lower limb was 190 millimeter mercury. Respiratory rate was 20 per minute. There was no pallor club. 130 by 44 was the wide pulse pressure. There's a wide pulse pressure, so the high circulatory volume. Not high enough, so systolic decapitation. Combined stenotic lesion. Probable stenosis of the aorta. Stenosis, regurgitation. 180. So upper limb, lower limb difference of, there was about 60 millimeter mercury upper limb and lower limb difference. So it could indicate a moderate, in Hill sign would be moderate.
So what are the other signs, peripheral signs of aortic regurgitation that you look for?
So flushing of the forehead, Landolfi sign, then retinal artery pulsations, uvular pulsations, then carotid, hyperdynamic carotid, and pistol short femoral, then Duroris murmur, which is a when we compress the femoral artery distally, we can hear a diastolic murmur over the femoral artery.
Check. What is that? Sorry. What is the, yeah, okay, that's all. It's a pulse wave that causes that Durosis murmur. Okay.
And combined stenosis and esophageal, you still got a collapsing, right?
Yes, sir.
What is classically described in a combined lesion? What is bisperance pulse?
It's an alternating low volume and high volume pulse.
2 peaks.
2 peak. No, sorry, 2.
1 peak or 2 peaks at the pulse? You got only one.
1 peak.
Where will you palpate for a disference pulse?
Carotid.
Yes.
There was no pallor, clubbing, icterus, cyanosis, or pedal edema, and she had a right eye thysis bulbi. Jugular venous pulsations were not elevated. There were peripheral signs of suggestive of aortic regurgitation present, such as the Duroris sign and Hill's sign. There were no stigmata of collagen vascular disorders or infective endocarditis. Cardiovascular system examination. Pulsations were noted over the carotid, suprasternal region, and left sixth intercostal space lateral to the midclavicular line. There were no scars, sinuses, or chest wall deformities present, and there was no visible parasternal heave. Apex beat was palpated over the left sixth intercostal space, 1 centimeter lateral to the midclavicular line, and is hyperdynamic in nature.
What are the causes of a hyperdynamic apex beat? And what is the difference between hyperdynamic and heaving?
So hyperdynamic is spread across 2 or 3 intercostal spaces, whereas heaving is localized to only 1. Hyperdynamic is to describe that the amplitude of the apex is higher than normal, whereas heaving, even the time of the apical beat is more than 2/3 of the systole, as well as the amplitude is high. Hyperdynamic pulses are seen in hyperdynamic apical beats are seen in conditions of volume overload, such as aortic regurgitation, whereas a heaving apex would be seen in pressure overload.
Volume overload, such as, give a few conditions.
Aortic regurgitation, beriberi.
Beriberi, how many beriberis have you seen?
None.
No, common things first, yeah.
Thyrotoxicosis.
No, mitral regurgitation, aortic regurgitation, PDA. Okay, say the common things first. Beriberi and all with the cardiac lesion, very, very rare, isn't it? Yeah.
Heaving is seen in conditions of volume overload. In pressure overload, like aortic stenosis, hypertension.
Okay. When will you get double apex beat?
Hypertrophic obstructive cardiomyopathy.
Okay.
Apex beat was palpated over the left sixth intercostal space, 1 centimeter lateral to midclavicular line, and is hyperdynamic. No parasternal heave was palpable, and P2 was not palpable. On percussion, the left heart border corresponded to the apex beat, and the right heart.
What is parasternal heave?
It's a when we place the ulnar border of our hand over the parasternal region, an impulse that is felt upon the ulnar border of the elevation.
Well, if an impulse, the definition is it's a systolic elevation of the lower costal cartilage. Can elevation occur in diastole? Yes. If you have an aneurysm of the descending aorta. So you have the parasternal heave has to be separated from pulsation due to aortic if you have an aneurysm. Okay. One is systolic, the other is diastolic. Okay.
On auscultation, S1 is heard best at the apex, and S2 heard best at the aortic area. A diastolic decrescendo murmur was heard over the aortic area, best heard in expiration, and a crescendo murmur heard over this systolic murmur heard over the apex as well as over the carotid.
No, see, when you describe a murmur, systolic murmur, the grade of the murmur is important. The character of the murmur is important. So you just cannot say, is it a long, small? So you have not described it in sufficient detail to convey the meaning. Systolic has to, what is the grade? How do you grade the murmur?
There are 6 gradings of murmur, sir. This was a grade 3. Grade 3. No. No.
So what's the grade 6 now?
Grade 6 murmur is you can auscultate the murmur even without the stethoscope diaphragm that opposes the chest wall.
Is it a long early diastolic murmur that you hear in addition?
Yes, sir.
Okay. Is there any other murmur in the mitral area?
I heard an apical crescendo murmur, systolic crescendo murmur over the apex. 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 Conducted to the carotid.
When you have a free-flowing, long, early diastolic murmur, what is the possibility of hearing some other murmur in the mitral area?
Can you have a functional diastolic murmur in the mitral area in a patient with severe aortic failure?
Yes, you can, because Austin Flint. Because of a functional mitral stenosis, because of the large volume of blood that is regurgitating. I heard a systolic murmur actually. Yes. Other systems relevant examination, trachea was central and normal vesicular breath sounds were heard bilaterally over. No features of failure, like no fail. Then no hepatomegaly present. Splenomegaly present.
What's your diagnosis?
So acquired valvular heart disease, probably rheumatic in origin with aortic regurgitation and aortic stenosis in sinus rhythm, not in failure, without pulmonary artery hypertension. No signs of infective endocarditis, NYHA1.
What is it? Is it a severe aortic regurgitation, moderate aortic? What you have to say the severity of the issue. Which is the more predominant lesion?
Aortic.
Is it stenosis lesion, or is it a predominantly or is it something else? How do you want to describe this?
I thought the aortic regurgitation was predominant, sir, and severity, because the Hills sign, the difference was 60 millimeter mercury, it would make it a moderate aortic regurgitation. Yes, sir. I yes. I thought because there was a systolic decapitation and murmur was radiating to carotid, I thought that it was a significant aortic stenosis as well.
Systolic decapitation. Systolic decapitation. Okay, so what investigation will you do to prove the diagnosis?
So I would do an echocardiogram, transthoracic, and chest X-ray.
Chest X-ray, ECG, echo.
ECG.
And yeah. What will you advise the patient? Surgery, early surgery, or late surgery? When will you? What will you advise in this patient?
Early surgery, because she was symptomatic for aortic regurgitation.
What is the natural history of aortic valve disease in terms of decompensation?
So usually within about 5 years after onset of dyspnea, we would expect cardiac failure to occur.
That's right. Yeah, what you said is correct. But once symptomatic, they have a fairly rapid downhill course. Average, if you talk about 2 years' time, they become grade 4. So if you have symptomatic aortic valve disease, you subject them for planning for surgery and replacement. Okay.
No, sir, I couldn't get that history. I didn't ask her.
Although they say, yeah, 15 minutes, but your doctor takes 1 minute to ask whether she can. Aren't you surprised that the mitral valve is where? Rheumatic.
Yes. Yes.
So what are the conditions can cause combined aortic stenosis regurgitation without mitral valve?
Hmm. Aortic root disease, but
No,
So-
only aortic valve involvement, stenosis, regurgitation. No mitral valve involvement, no history of rheumatic fever. What etiology would you consider? What's a common thing?
um,
Is there a
syphilis.
click? Is
But-
there an aortic ejection click?
No, sir, I didn't get that.
You
yet.
can't hear it. Okay, fine. So you need to think about a bicuspid
Bicuspid.
aorta. Okay, that can present like that. Okay. Think we'll. Okay.
All right.
Philip?